and 5. Let's go to the next one, our HBTSSN anthem. 1, 2, go. HAEMATOLOGY, blood transfusion science, by home of all blood scientists. Bloodology, bloodology, the mystery of the creation. Like drop of blood we've come to stay from every state in Nigeria. HAEMATOLOGY, blood transfusion science, my home of all blood sciences. I heard my president say we should repeat it again. Thank you very much.
A round of applause to yourself. That was a beautiful one. Wow. Our anthem is very nice. Woo!
Distinguished guests, ladies and gentlemen, that was a very wonderful anthem we have taken. I understand why Mr. Ransom Jacob wanted us to take it again, because he knows our president and every other member of the HBTSSN members, they love our anthem so much. You always want to hear that when they mention blood. We are to take the product presentation. Product presentation. Patek Healthcare, are they in the house? Patek Healthcare. Okay, if Patek Healthcare, they are yet to come, please, we'll go straight to the chairman's opening speech. Put your hands together as we welcome Professor C.K. Wachiku to take us through the opening.
Somebody was invited to chair an occasion like this, and he invited me today. Then he looked at the high table. He saw the enemy in the high table. He said, all protocols observed. Yeah, you are the first to speak. Which protocol are we observing? You have to set the protocol. So, since I don't have any enemy here today, I will observe the protocol. All right, let me recognize the president of the Hematology Association in person of Professor Jeremiah. Welcome. I also want to recognize the president of the Association of Medical Laboratory Scientists of Nigeria, Dr. Obi Thomas. And then my own friends, who have known ourselves for years, during the time of Professor Famodu, late Professor Famodu. And when I was HOD, I keep bringing here. In fact, I was the one who brought him to this school to be examining students. So, he's a professor. Are they or what is? I'll do tell you, thank you very much. So you can see I don't have any enemy here. And I recognize all of you, distinguished ladies and gentlemen, gentlemen of the press, and our comedians, our MCs. I recognize you and welcome you to this program today in Jesus' name. I want to say I'm highly delighted to be honored this way. It's not easy for you to call somebody to come and chair this important occasion. In fact, I'm one of you. I'm a male lab scientist. It's just that I'm a microbiologist. I'm a professor of applied microbiology and also the dean of this Faculty of Science. So, the theme for the World the Thrombosis Day is very apt and very important in today's healthcare delivery system. When I looked at it, eyes open on thrombosis, I said, was he blind before? who was the cause? What, was he blind before? And I looked at it, I said, okay, if he's blind, it will open today in Jesus' name. And I know that why they chose that team is because little or no emphasis has been laid on thrombosis or thrombotic disorder in the country, in our state. And so what the World Thrombosis Day is doing is to create more awareness on the issue of thrombosis or thrombotic disorder, as the case may be. The reason is that you are hematologists and scientists. If I begin to explain it again, it may lose. But let me try again for the purpose of those who also recorded me today. When you talk about thrombosis, the little I know, we're talking about when there's blood clots in a vessel that carries blood. A blood clot in a blood vessel, which is an abrasion. Ordinarily, blood flows through that vessel to major organs of the body. And if there's obstruction, it will create a problem. It will impair the organs of the body. One thing that happens is that it has semblance with air pollution. In microbiology, when we talk about air pollution, we talk about carbon monoxide inhalation. What does it do? Carbon monoxide also obstructs the release of oxygen. And when there is an obstruction of blood flow as a result of blood clot, oxygen, because the blood carries oxygen to major organs of the body, not so, and then the oxygen will be obstructed. If those organs of the body that requires oxygen to function maximally will be retarded, will have problem, and then there might be some health risk, health challenges, and that is why eyes must be open to thrombosis, so that neglect, people can now know what to do about thrombosis and thrombotic disorders in our health sector system. It is very important. So more awareness is needed. It shouldn't end here today. More awareness is needed to tell the people about thrombosis in the health sector, anywhere people should be to think about it. Because I know that there are so many diseases or health challenges might be as a result of thrombotic disorder. I heard somebody say that they talked about thrombosis and COVID-19. They have some resemblance. Not so. So I want to thank you, but I will not end my short speech today without appealing to health professionals. I want to appeal. Let us try and end these professional bickerings. Let us try and end this beauty contest in the health sector. Let us know our boundaries. Whether they may lab scientist, whether a doctor, pharmacist, nurses, know your own boundary and work within that limit. And that's the only way healthcare delivery can be better in Nigeria. And that's the only way we can talk about thrombosis and add more value. I want to thank you so much for this honor done to me. God bless you. And I want to use the opportunity again as the chairman, my capacity as the chairman, to declare this World Environment Day open to the glory of God. Hey! World Thrombosis Day! Hey, pardon me. You know, I'm sorry. You know, as a microbiologist, I'm an environmentalist. I've been the chairman of Nigerian Environmental Society, and then I'm also the national editor. So I want to declare this World Thrombosis Day open. Thank you very much. I'm really sorry. Thank you.
Yes. That was a very wonderful welcome address by Professor C.K. Nwachukwu. You know, when you are a prof, because of the amount and number of books you have read, you are speaking like you are in, you have your own, you are an authority, so you have the free will to speak. Imagine policeman stopping you at a checkpoint is asking for a document that is not relevant, and when you ask him, he said, "Don't you know this is my duty?" Because he has an authority, his uniform is giving authority. So it is in the same vein, Prof has authority to speak. Once again, let's put our hands together for Professor C.K. Nwachukwu.
Indeed, Professor. Okay. Next on the list, we have a keynote address on Eyes Open to Thrombosis by Professor Ifedayo Ajayi, all the way from University of Benin. A round of applause for him as he comes to take the podium.
Ladies and gentlemen, can we call on Professor Olutayo Ifedayo Ajayi? Is one man is one man who does not have English name. He's pure Yoruba to the core. So he doesn't have any English name. I just want to say a few things about him. It's not just, it may not be the citation that we really want to, if you want to read the citation, we can be reading the citation from now till the program will be over. And we will not finish it. Because he's a man of many parts. So permit me to just make a brief about him so that you know who is talking to you. Are you with me? Professor Ifedayo Ajayi was born when his mates were born. I know he's from Ondo State. And he schooled when he schooled at where he schooled. From the time we knew him, he is a medical laboratory scientist, first of all, who has practiced on the bench for several years before he went into academics. He had degrees in physiology, both masters and PhD, and is combining the physiology with medical laboratory science, which is very, very, very excellent. So most of what is going to be talking with you is going to look at the medical laboratory perspective and then using the physiological background to provide explanations. That is what makes Professor Ajayi very unique. So he is well published, well traveled. I don't think there is we have few professors in this country that very few that travel like him. He is well versed. And right now, I think are you still the HOD? He has handed over. He was the HOD of physiology from University of Benin and is contesting for headship, for a deanship, and is asking for your prayers. He want to be like Professor Wachugu. All right, so when we were planning for this event, I wanted to get the best hand to tell us what eyes open to thrombosis means, because it's a word that is encapsulated. And then we said, well, for this occasion, I think he's the rightful person to give us the information we need. So he has traveled all the way from University of Benin. If you have traveled before, you know how the road is. He dared all the roads, all the bumps on the road to be here yesterday. He's here in our midst to give us the lecture on the theme, which is eyes open to thrombosis. I believe he is well prepared and is going to deliver what God has given to him to deliver, because only what God says he will say that he will say. And what the science also asks him to say that he will say. He will not say anything outside science. So please join me as I call to the podium our guest speaker, our keynote speaker, who is in person of Professor Olutayo Ifedayo Ajayi, to the podium. Thank you. Welcome. I hope I did something. Sorry. Professor Ifedayo Ajayi is a member of the Hematology and Blood Transfusion Scientific Society. That is why he is more qualified to speak here. Thank you.
Thank you very much. What's the mode of using this projector? You change for me? Oh, okay. You have to be dynamic then. All right. The chairman, sir, I want to appreciate you for those opening remarks. And I can see the kinetic energy in you in trying to be in hematology. No problem. You, for today, at least for, you have been a lab scientist, you are a member. And so we appreciate the much you gave us on thrombosis. And actually, the microbiologists have their own role there. Somebody talked about COVID yesterday. And of course, one of the major risk factors are inflammatory reactions, which is basically coming from the microbiology end. The president of the society, I want to appreciate you also for speaking eloquently about me without looking at my papers. I know we've been together for a very long time. And we'll continue to be together in Jesus' name. The organizers of this program, the South-South, the River State branch, I want to appreciate you for making it possible for us to be here and to talk on this worldwide theme, Eyes Open to Thrombosis. Thank you for inviting me to speak on this, and I hope will not disappoint you. And to all members of Hematology and Blood Transfusion Society of Nigeria, I want to welcome you all to this day, and I want to thank you for inviting me to be here. I will try as much as possible to do the little I can do on this. I think this place is a bit too far from me, looking at the screen. I will talk on this in many ways and try as much as possible to not to bring something new, but to reiterate what we already know. And looking at the lecture topics for yesterday, most of the jobs have been done. I just need to recap them and try to make them sink so that everybody will understand what we are preaching. And actually, it is not meant for us. It is meant for us to be trained to be able to enlighten the public on what thrombosis is. We all know what thrombosis is. We are practitioners in the diagnostic world. And of course, our job is to know who has thrombosis or who doesn't have thrombosis. So it is for us to now let the world know that when things like this are happening, these are signals for you to know that you may be liable to have a thrombotic complication. So quickly do this or quickly do that. Those are the things that we meant by eyes open. It's not as if our eyes were closed, but awareness was very low. Up till now, people may not even know that the highest cause or the greatest cause of death is thrombosis worldwide. And of course, as men ages, so their activity dwindles. And once this happens, this is already a risk factor. Immobility is a risk factor for thrombosis. And so we need to let people know that this is what happens. And so when you start seeing, like we are talking about COVID now, we talk about new normals. When we start experiencing new normals in our lives, we need to understand that something is beginning to change. But the best man in this world is the man that is able to adapt to a new change as fast as possible. So we need to just look at, not just to condemn ourselves. I don't know what is wrong with me, this and that. These things can come, these things can be overcome. So we need to understand where we are. Can we have the next slide? This is the message from the World Thrombosis Day by the IST, and what it's saying is all as it's saying. Let us all come together and take a vow to educate at least one person about the disease of this World Thrombosis, on this World Thrombosis Day. So let us be able to educate one person that thrombosis is real, and we'll be able to carry out the message. Next slide, please. This will be the outline of my presentation. I may not follow it the way it is, but I will touch on almost all what you have there. Next slide. And so if we look at it from the biblical end, blood, just like the hematology anthem, just our anthem, just said that like drops of blood, we've come to stay. So, for the life of a creature is in the blood. And I have given it to you to make atonement for yourselves on the altar. It is the blood that makes atonement for one's life. So you realize that blood is life. That is what it's all saying. Whatever it is we do, without blood you can't do anything. And so Prof was telling us how blood carry oxygen and deliver it to the tissue, take carbon dioxide and bring it outside. If that is not done, then definitely there is no life. That's what it means. Next slide. That's in Leviticus 17:11 or so. Now, overview of thrombosis. It's been given yesterday as an overview.
but I'll just give an introduction to it. Thrombosis occurs when there is an imbalance, actually when there is an imbalance in blood coagulation system, which causes a blood clot. And that blood clot we're talking about now is the appearance of a solid mass within the blood vessel, within the bloodstream. In an untouched blood vessel, you see a blood clot. And of course, this denies oxygen and nutrition to an area of the body. And so if that happens, that area that is denied, because the clot will block it, so no further transmission of oxygen and blood and food supplies, definitely that particular area will start dying. Acute arterial thrombosis often results from the deposition of material in the wall of an artery, which gradually narrows the channel, precipitating clot formation. We have a blood vessel that is gradually narrowing down. What does this bring about? It brings about stasis. And we're going to talk so much about this to try to understand the mechanisms underlying all these things, how they interact together to bring about thrombosis. So thrombosis in either the arterial or venous system is a leading cause of significant morbidity and mortality. And this is a fact that is known to all of us. Next slide. When thrombosis occurs in the arterial system, we talk about myocardial infarction, and stroke may ensue, whereas thrombosis in the venous system leads to venous thromboembolic disease, which is where you have the most occurring one, the deep vein thrombosis. But here we have a myocardial infarction. It could be in the coronary circulation, it could be in the brain, and so we start talking about stroke, or we start talking about heart failure. The major outcomes of venous thrombosis are death, recurrence of the thrombosis, because once you have it once, the tendency to continue to have it repeatedly is there. It's like the system now knows that this is, so any little signal, it goes. So recurrence is a major problem, post-thrombotic syndrome, and a major bleeding due to anticoagulation. Because when people are trying to now treat thrombosis, there is a blood clot. What they treat it with anticoagulant. And the excessive use of anticoagulant leads again to bleeding. And that is the basic thing that we need to know, the balance in hemostatic system. We live between two dangerous extremes. Too little, too bad. Too much, trouble. So we have to be on that physiological range, and that is what we call the homeostatic range. So we need to balance that together. Thrombosis is also associated with impaired quality of life, particularly when post-thrombotic syndrome develops in humans. And so we need to understand that this is where we are, and these things have come to stay. Next slide. Thrombosis may extend into vessel without blocking it completely, whereas when there is the onset of myocardial infarction, it's just extending into the vessel, it's not blocking it completely. And we are going to talk about this as alteration to blood flow, which is a major determinant here. It's a major determinant in the generation of thrombosis. There is stasis, there is narrowing down of the blood vessel, and so blood will pass through, but not at the same rate that they used to know. And we need to understand the basic principle, well, we just remind ourselves the basic principle of the blood vessel architecture, so that we know what is actually happening within the blood vessel before this thrombosis will come up. Then it could block it completely. That is where we have occlusive thrombus. And of course, extend along the vessel wall, the blood vessel, that's a propagative thrombus, which is usually the example is the DVT. Next slide. History and epidemiology. Where are we coming from, and what is the distribution rate? The first well-documented case of DVT was reported during the Middle Ages. In that, in 1271, unilateral swelling and edema developed in the leg and ankle of Raoul, a 20-year-old Norman cobbler. He was advised then to visit the tomb of King Louis IX of France to seek his healing power. He actually did this, and miraculously, he got well. And so they believed that it was the dust from that tomb that healed him, which is usually not true. What happened was probably may have survived it, due to natural anticoagulation, and he survived. And he lived for 11 years thereafter. Next slide. After this report, the identification and documentation of cases of DVT began to increase. They were primarily noted in pregnant and postpartum women. The clots were believed to be a consequence of the retention of evil humors. That's what they call blood those days, humor, hot humor, during pregnancy and at postpartum. In the 17th century, the humoral theory was gradually abandoned, and in 1676, Weizmann hypothesized that blood clots were due to abnormalities within the blood. Later in 1793, Hunter proposed that DVT was a venous occlusion caused by clots. He introduced venous ligation above the thrombosis, and this helped to reduce incidences of thromboembolism. Because what they do is, okay, there is a clot down the line, you ligate it, you tie it up there, so that even if it can no longer go beyond that range. So there is no thromboembolism that could extend to any dangerous part of the system. And of course, nature will have a way when you close that particular vessel, there will be another spring veins that will join that particular one that takes blood to that particular area. So that one can just be condemned, another one will sprout up. Next one. Next slide. So although pathologic hemostasis was described as early as 2650 by the Chinese physician Huang Ti, not until 1856 AD did the German pathologist Rudolf Virchow publish his triad of factors contributing to the development of thrombosis. This has led to further development in the theory of thrombosis till date. So the triad, the Virchow triad, we still use it to teach students up to tomorrow, because that is the basis. We only extend the knowledge from what the man defined. Next slide. So epidemiology continues. Venous thrombosis, comprising deep vein thrombosis and pulmonary embolism, occurs with an incidence of approximately 1 per 1,000 annually in adult populations. Rates are slightly higher in men than women. Above 2/3 of the episode manifest as DVT, and as 1/3 as pulmonary embolism, with or without DVT. Venous thrombosis is a disease of aging with a low rate of about 1 per 10,000 annually before the 4th decade of life, rising rapidly after the age of 45, and approaching 5 to 6 per 1,000 annually by the age of 80. That's Silverton in 1998. So we now know we can classify ourselves where we belong. We have not too young to run and not too young to be sick, so we should know that. Next slide. Thrombosis and thrombotic related events are among the most common causes of mortality in the Western world. It is written in the Western world because they are the only ones that have documents to show for it. It's not as if it doesn't kill us here, but we don't have data. There's nothing to tell us that this is what killed this person. Most of the time, they just did a post-mortem, they see blood clot, but you have to identify what type of blood clot you see. Is it a pre-mortem clot or a post-mortem clot? These are little things that we really don't bother much about, and Africans don't care about what killed somebody. They just accept it is the will of God. Stroke also accounts for, it is estimated that 785,000 people in the United States had new thrombotic events within the coronary circulation in 2009, and that over 450,000 had recurrent events. We mentioned recurrence as a problem earlier. So stroke also accounts for significant morbidity with 795,000 people per year and so on. So there are 200,000 new cases of venous thromboembolism each year, 30% of which result in death in the first 30 days after diagnosis. Next slide. Now, these are the risk factors. I'm not so comfortable with the way I'm standing. I have to stretch. I'll be okay here. I'm okay. So risk factors for thrombosis. Looking at thrombosis, we can see that we have them, both the hereditary thrombophilia, and of course we have the acquired thrombophilia. And of course, atherosclerosis, that's the narrowing down of the blood vessel due to atherosclerotic plaques, and the surgical maneuver that could make people to touch the major blood vessels could cause problem with the vascular endothelium. We are going to look at the endothelium as the major source of this very soon. Hormonal therapy, especially estrogens, malignancy, inflammation, and immobility. That's where old age comes in. These are all risk factors for thrombosis. Next slide. And so when we break that down, you look at the genetic risk factors, you are seeing people that have anticoagulant deficiencies, especially factor V laden, prothrombin, and of course, acquired can be age, previous venous thrombotic episode, cancer, obesity, and so on. These are all triggering factors. Pregnancy, surgery, immobility, trauma, long travel. If you travel from Nigeria to United States, you are going to cross the Atlantic. And the fastest plane that will take you across the Atlantic will do it in 8 hours. And so if you have to do it in 8 to 10 hours, then of course you know it's a long time you have traveled. And so along the line, don't just sleep all through. Get up, walk around, find a way to exercise your feet, your toes, and so on and so forth. These are things that, and if you are now an incessant traveler, that you have to travel every now and then due to the nature of your job, then you know that you have a risk here if you don't do what you need to be doing. Next slide. So pathophysiology of thrombosis, this is, like I said earlier, it's all based on the Vercau's triad. But I'm not going to dwell so much about this unless I lay a basis for us to understand exactly how injury to blood vessel, stasis of blood, increased coagulability of blood, how they become thrombophilic factors, and how all of them contribute to the pathogenesis of thrombosis. So in general, we're going to see vessel injury being the most important contributing factor to arterial thrombosis, such as heart attack and stroke, while stasis and increased coagulability are more important in venous thrombosis. But you're going to see that the triad, they circle within themselves. One leads to the other. The other leads to the other. So you know that the three of them, the three factors, when one starts happening, it can disrupt, it can instigate hypercoagulability, or it can instigate stasis of blood. We are going to look at that and see exactly what we are. I think by the time we have that, we have the knowledge, the scientific basis of what we need to use to convince people that this is how thrombosis happens. Next slide. That's the triad according to Vercau, and that is the first one there is hypercoagulation of blood, vessel injury, and of course stasis of blood. This is what we've seen earlier. Next slide. So the endothelial injury, like I said, there is alteration to blood flow, there is hypercoagulation, there is endothelial injury. Once endothelial injury is at the top of it all, the alteration to blood flow will come because endothelial injury will release a host of substances that will instigate either hypercoagulation or alteration to blood flow. And if it is alteration to blood flow that starts it all, it's going to cause endothelial injury at the end of the day. And that is more like a positive feed-forward reaction. Because one process has started, is leading to the next one for further increase in the activity. And at the end of the day, thrombosis is at the central dogma. Next slide. So what are the scientific bases for all of this? I'll crave your indulgence to allow me to talk a little bit on all these things so that we can understand where we are coming from. Vascular system. We've just talked about injury to the endothelial cell or to the endothelium. Blood vessels, we have the arteries, we have the veins, and of course we have the capillaries. And of course we know that from the arteries, the major artery that the heart pumps blood to is the aorta. And the aorta is a big pipe that supplies all the bigger arteries. And so the bigger arteries are the ones that give rise to arterioles. And of course the arterioles give rise to capillaries. So as you go down the line from the aorta, you realize you have a big pipe. And those other trajectories from the aorta are smaller than the aorta, but they are larger arteries. These larger arteries will supply major organs. And within the major organs, you have the arterioles, which are the ones taking blood right deep inside the organ. Then this one gives rise to capillaries. Why do we need capillaries? We need capillaries because capillaries are blood vessels that are single cell thick. in their wall. Arterioles have smooth muscles behind the endothelium. And so if you want to give oxygen out to the tissue, you won't want the oxygen to cross through one cell, pass through smooth muscle cells before it gets to the tissue, because those cells also will take the oxygen. Now, capillaries just one single cell thick, and it takes only one red blood cell at a time. There is no way you have two red blood cells passing through the same capillary at the same time. No. Nature has it in a way that there are millions of that. And so red blood cell goes sequentially one by one, and they deliver what they are carrying. The oxygens are unloaded, and they load the carbon dioxide from the surrounding tissues. So now this red blood cell, when it drops this, it goes into the venules. The capillaries are anastomosed with the venules, and so the venules becomes the big veins. And so gradually you now realize that this, as we go further, the vessels become smaller and smaller until you start seeing them rising again. Venules are smaller too, and so venules become the larger veins that takes blood back to the heart after they must have taken the carbon dioxide. Next slide. That's exactly. Do you have a pointer? Actually brought, but I didn't put battery. Now you have the artery, you have the vein on the other side, and you can see the major artery giving up to become arterioles, and the arterioles are becoming the capillary network. And so you can see the size of the capillary down. Another slide will tell us more about that. Then the veins, one thing we need to take home from here is that the arteries, if you look at the blood vessel wall of the arteries, they are very thick because there are a lot of smooth muscle cells. A whole lot of activities are going on there. You have that also in the vein, but they don't have so much. The vessel wall in the veins are not as thick as that of the artery. Next slide. Now that is a capillary. You can see all it does is just one single cell can pass through. And so it is very easy for this single cell to just deliver the oxygen to the surrounding tissues and move on. Next slide. So this is the anastomosis now. This is the artery, the vein is there. So you can see the arteries coming down, giving off branches, and the branches are beginning to form capillary bed, and this capillary bed through their thoroughfare, they join the venules, and the venules come to become the big veins and take blood back to the larger vein that take them back to the heart. Next slide. So what do we have inside the arteries? Inside the blood vessels, we have endothelium. That smooth inner lining of the blood vessel is the endothelium. We call it the cellophane lining of the endothelium. Now, of the blood vessel. It's a single layer of endothelial cells. It's coated with glycocalyx, protects the basement membrane, and produces von Willebrand factor and thrombomodulin. These are the normal function of the endothelium. Secretes heparin sulfate, which ends in producing, in helping to activate the helping us to make sure that antithrombin 3 is produced, which will help us to make sure that there is anticoagulation. Then secretes prostaglandins, plasminogen activators, and nitric oxide. All these are going, especially the nitric oxide, are going to help to dilate the blood vessel ordinarily. But they help at the end of the day to repel circulating proteins and platelets from touching the wall of the blood vessel. We don't want anything, we don't want any interaction within the vessel wall. That is why we are saying injury to the vessel wall is a factor here. Any slightest injury to that vessel wall is a trigger for so many complex reactions. Now you have the subendothelium area, just the layer after the endothelium. And these ones will help us to, that is where you have the collagen fibers. And you know the role of collagen fibers, thank God we are hematologists. When it comes to platelet, relativity, they are very high affinity for platelet. And so nature protects that collagen from being exposed. But any slight injury, these things are, the subendothelial tissues are exposed. Next slide. And so the collagen material, it will definitely stimulate platelets. And of course, the elastic fibers supporting that also provide support around the blood vessels. Next slide. So now, what happens to when there is vascular injury? That is when we have normal function. But what happens when we have vascular injury? Next slide. It produces von Willebrand factor, which helps in platelet adhesion to collagen. That injury has come now. And it carries factor 8. It is able to bind to factor 8. Tissue factor activates secondary hemostasis via extrinsic pathway. And tissue plasminogen activator is also released, activating fibrinolysis. These are normal things that happens when there is disruption. But if there is a disruption, if there is a cut in the blood vessel, this is when this becomes useful to us. But there is no cut, but there is an internal injury to this blood vessel. The same thing the blood vessel will do is what it will do ordinarily. It will still help you to produce clot, but this time around, it is no longer a help. Next one. Release of tissue plasminogen activators, activate release of plasminogen activator inhibitors to inhibit fibrinolysis. These are all the inhibitors that are released as well. Then we have thrombomodulins, which forms a complex with thrombin and so on. And also prostacyclin. All these help normally. Next slide. Now the function following the injury is to initiate hemostasis. And so you have vasoconstriction of the arterioles. This is to minimize, physiologically it is to help to minimize blood flow to that area, so that you don't have too much blood gushing out when there is an injury towards outside. But this is now injury that is not going to bleed out, but bleed straight into the tissues surrounding it. Then you can imagine that the nature is still taking its own due course in trying to stop that flow of blood. But that due course is a problem that we are contending with. Next slide. Also, you have the neurogenic factors that the vasoconstriction would stimulate. This is when you now feel pain if there is a cut on your blood vessel. Because there will be a local mechanism, a neural local mechanism there because of a lot of injuries straight to the smooth muscles. And what they do is they vasoconstrict, and they send signal to the brain processes that and brings it as a nociceptor pain. And so you see the pain back. And so if you are cutting your hand, you now know that you need to withdraw your hand from there. And so all these things will help. When there is prolonged vasoconstriction, then you are going to have a whole lot of this happening. Serotonin, thrombosin A2, endothelin 1. These are all pro-platelets factors. Next slide. Now, in hemostasis, we are very well acquainted with all this. The vascular system, which is the vasoconstriction, the phase, then the platelet follows that phase, then the coagulation system, the big brother of them all, will come to cement whatever platelet must have done, and we have the fibrinolytic system after injury, tissue repairs, and of course the coagulation inhibition system must take over later. Next slide. So what happens now when there is an imbalance here is where we have vascular injury. The imbalance is now going to cause a failure or deficiencies in any of these 5 systems can lead to varying degrees of uncontrolled hemorrhaging or clotting. So like I said earlier, too little, too bad will give us bleeding, too much will give us clotting. But now there is an imbalance now because there is a vessel wall damage. And so something is going on, but the bleeding is not towards the outside. Can we go to the next slide? So we are also acquainted with this particular pathway, how blood coagulates. And of course, the central point there is thrombin being activated. And you can see what thrombin can do. Thrombin alone, once it is being activated from the extrinsic or intrinsic pathway, whichever pathway is coming, actually the extrinsic takes over even the intrinsic. Because these days we now realize that even the intrinsic mechanism usually is a bit too slow. You need to go to 12 to 9 and all. But we now realize that factor 7, once it is activated, can activate from factor 9 down and bypass the factor 12, factor 11 mechanism. So you see a very explosive reaction taking place. Now, the end result is that a thrombin is going to be generated. It's going to be activated. And so once thrombin is formed, thrombin can create clot via fibrin pathway, and is going to help to activate more platelets. And platelets are going to release more of even the thrombin. And of course, thrombin can go and activate the protein C mechanism, and the cycle continues and continues and continues. But the important thing is that if there is an imbalance here, there's going to be a whole lot of problem. Because the imbalance now, if there is no balance between the fibrinolytic pathway, the anticoagulation pathway, and the clotting pathway, if the clotting pathway takes more precedence, then there is clotting. If the anticoagulation pathway takes more precedence, there will be bleeding. Next slide. Now, we've looked at what happens to the blood vessel. What now happens to the blood flow? Remember, we are talking about the Verkaus triad. We've looked at the pathogenesis of how the injury to blood vessel could cause trouble. It's because so many things could happen to the endothelium, and once the endothelium is injured, it has to do its natural job, which is to make sure that it responds physiologically. But at that point in time, responding may be a problem. Now, let's leave that aside. We'll come back to it again. The blood flow, the actual blood volume flowing through a vessel, actual volume of blood flowing through a vessel, an organ, or the entire circulation in a given period. That is what we refer to as blood flow. And it is measured in ml per minute. It's equivalent to the cardiac output, what the heart can pump in 1 minute, considering the entire vascular system. It's relatively constant when at rest. Varies widely through individual organs according to immediate needs. And of course, this tells us that what the liver, when there is need for it, may be more than what the skeletal muscle takes. When you are at rest, you don't need the skeletal muscle. But when you are explosive, you are having exercise, you can have as much as 25% to 30% of the total blood flow. Next slide. Resistance now. We talked about narrowing down of the blood vessel. And when you narrow down the blood vessel, you are creating resistance to blood flow, isn't it? Yes. Now, changes in vessel diameter are frequent and significantly alter peripheral resistance. And resistance varies inversely with the fourth power of vessel radius. What that is saying, we do some mathematics and physiology on that. If you have this diameter of blood flow, if you reduce this by half, you have increased resistance 16 times. So if you drop the diameter of the blood vessel by half, resistance has increased 16 times to flow, which means flow to the organs beyond that resistant place is seriously hampered. Next slide. Small diameter arterioles are the major determinants of peripheral resistance. Next, don't rush too much. Fatty plaques from arteriosclerosis, like we see when we have deposit of cholesterol on the very tiny arterioles. Most of these are very tiny vessels that we cannot, they are microscopic. Now you are depositing fatty plaques around them. Remember I said a drop by half increases resistance 16 times. Now, once you have increased resistance, blood that is flowing to that area is not aware that there is a resistance. The heart pumps normally. So the blood given to that particular organ is given, and it gets to that place, and there is a roadblock. Then there is turbulence. Blood normally will flow in a laminar fashion. What do we mean by laminar fashion? Blood flows in a concentric layers. If you remember the vessel wall architecture, blood will not get near the wall because of the endothelium. And again, it is negatively charged at the endothelium. So most of the blood cells are negatively charged, so they are repelled towards the center. And so they move. And you now see that the velocity with which they move, the ones at the center is the one that move fastest and farthest compared to the one at the periphery. But those ones have to contend with whether being repelled or being attracted and so on. Now, there is turbulence. Blood that is flowing radially and axially, that is flowing straight, will start turning back. And when they want to turn back, they roll back. They just get there, they meet a block, and so they keep spinning back. That's a turbulent flow. And when this happens, remember, these are cellophane lining single cell thick endothelium. It could cause destruction of that endothelium, and that may be the site of an injury to that blood vessel. Now, this will cause turbulent flow and dramatically increase resistance due to turbulence. Can we go to the next slide? Now, the flow rate through the blood directly proportional to the pressure gradient, because the heart is the source of the force that drives the blood through the blood vessel. Now, the heart will feel it after a long time too, because blood is no longer going, so there is a reverse pressure heart. Let's leave this mathematics. Go to the next one. Now we're talking about the laminar flow and the Reynolds number. I just explained what laminar flow is all about. Blood flows in a streamline and a concentric layer, resulting in a parabolic profile of velocity within the blood. Next. And the velocity of blood is highest, I said this earlier, at the center of the vessel and lowest towards the vascular wall. Next one. The parabolic profile develops because the layer of blood next to the blood vessel wall adheres to the wall and practically does not move. The next layer of blood slips past the motionless layer and moves faster. And of course, the velocity of flow at the wall is 0, and the velocity at the center of the stream is maximum. Next one. So when an irregularity occurs in a blood vessel, either at the valve point or at the site of a blood clot, there could have been a blood clot that is flowing freely. Ordinarily, when they flow in larger vessels that are bigger than their size, there is no problem. But the moment they get to a vessel where they cannot pass through, they block it. Now, turbulent flow will ensue from there, because the blood now hits the wall. The solid mass, remember we define thrombosis as solid mass flowing freely in an intact blood vessel. Now it hits this and there is turbulence. So instead of the blood to move laminally, they now mix radially and axially. You see them rolling in one place. Next one. So now we talk about Reynolds number, which is a dimensionless number that is used to actually know, to predict whether flow is turbulent or not. Next one. So if Reynolds number is less than 2,000, then blood flow is laminar, is normal. But when it's greater than 2,000, there's an increasing likelihood that blood flow will be turbulent. But once we have 3,000 and above, it is an absolute conclusion that there is turbulent flow. And this could be as a result of thrombi that have been deposited. Next one. So the major determinants for Reynolds number are blood viscosity and blood velocity. Next one. Next slide. Now, we have seen how blood flows. What now happens when there is alterations to the normal blood flow? One, there will be turbulence. And once there is turbulence, arterial and cardiac thrombosis may result from there, because there will be endothelial injury or dysfunction. Then there will be stasis, because blood that is supposed to be flowing is now staying in one place. They are not moving as they are supposed to move. So that gives room for blood cells to interact, and platelets could be activated along the line. You and I know that once two platelets should touch each other, that is, activation has started. And so it goes on and on and on. So that disrupts laminar flow, platelet into contact with the endothelium. And that's, once that has happened, problem has started. It prevents the dilution now of the activated clotting factors. Because as we are sitting down, there are clotting system going on. We call them runaway clots. They happen even when you are sitting there, when you are not active. But we have defense mechanisms in fibrinolytic activity that helps us to clear them as often as they are formed. It's just that when this now overpowers the other, then that is where problem is. And this now is being exaggerated because there is turbulence. So it also will retard the inflow of clotting factor inhibitors and so on. Next slide. Contribution of turbulence and stasis to thrombosis. Ulcerated atherosclerotic plaques will be source of turbulence. Abnormal aortic and arterial dilations and aneurysm favor site of thrombosis. We are just saying now based on flow. But the relationship between blood flow, blood pressure, and resistance is a much more complex thing. And that is beginning the generation of probably a high blood pressure. And that's when there is high blood pressure, pressure is high, blood is not flowing. What happens to the wall? The wall will be will be disrupted. And so there could be an injury to the blood vessel wall. And what we have in the blood vessel wall, usually the endothelium secretes nitric oxide, which always help us to vasodilate the blood vessel so that blood can move freely. But the endothelium is damaged now. no more nitric oxide synthesis, and so blood remains the blood vessel remains in a very tight radius, always in contracting phase, and that increases the pressure because there will be a backflow of pressure to the heart. And so when you measure your blood pressure, you are actually measuring blood pressure as it is distributed on the blood vessel walls, so that you can use that as a measure of what the heart is doing. And so the heart feels that this blood is not moving. Let me increase the pressure. It increases the force of contractility. And so the heart is beginning to generate much more pressure than you need. And so it's beginning to cause much more damages to other organs as well. Next slide. Now, looking at that thrombotic event now, we've looked at, of course, we know hemostasis. We've looked at the vascular processes in hemostasis. We've looked at what happens to cell wall injury. And we have also seen problems that will arise from blood flow. If we combine these three, where are we? Combining these three, you will see a disruption in the vascular endothelium. And of course, it's going to expose the protein within. I mean, the injured site is going to expose the underlying layers. And we know the complexity of events that will take place once that has happened. Platelets interaction will go on, and before you know it, a thrombus is formed. You only need just a single thrombus to cause problem for the entire system if that thrombus is not quickly taken care of. And that is why you realize that in advanced countries, the moment you get above 40, 45, they advise that a low dose of aspirin per day is good enough. Because you never can tell, because your activities are beginning to come down and you don't move as much as possible. We know that in the literature, exercise have been linked inextricably with a good fibrinolytic system. That you are exercising, you are moving around, your fibrinolytic system is active, and so all these runaway claws that comes around are taken care of immediately. But when they are not taken care of, they exist in the system, and they predispose to so many complex reactions. Next slide. So now, you'll be going one by one. Now we have endothelial injury, next. We have alteration to blood flow, next one. We have hypercoagulation. We've explained how these three will come. Then the next one is that, next, you realize that endothelial injury can have a reverse interaction with alteration to blood flow. And alteration to blood flow can improve, they can stimulate hypercoagulation. And hypercoagulation can also stimulate again endothelial injury. So we are moving in a cycle of danger once one is activated. Next slide. So this will now finally, thrombus will have propagation stage, embolization stage. If it is propagated, which means it is sustained, then the possibility of one part of it chipping out and moving across, leaving the other thrombus behind is possible. And that can go ahead and block other blood vessels. But if it blocks the pulmonary arteries, then that's where we have problems in breathing. And that's where COVID or whatever is doing its own issues in. Then the dissolution, if there is a good fibrinolytic activity, it could be removed, but if not, it stays. Then if it is staying, a time comes that the thrombus is beginning to home itself along the blood vessel. It wants to stay, it wants to establish itself, and so there is what we call organization and recanalization. Capillaries will pass through these thromboses, these thrombose vessels. Capillaries will find their way through it to get to the tissue so that it can supply blood. Meanwhile, the thrombus remains where it is. Next slide. So clinical and laboratory management, like I said, most of these things have been talked about, but I just talked about it and let us see our own. That's why I said clinical and laboratory management. There is no way one person can claim the total knowledge in managing thrombosis, except you want to kill people. The doctor cannot sit down in his office and start prescribing anticoagulants without a laboratory management aspect of it. You're going to kill that patient. Because it is the lab that tells you this is the prothrombin time of this patient, and when you give a dose, we monitor until we establish a dose for you, control with our test. When you start calculating your PT, your INR, and so on, you don't let them know that once we have, the ideal thing is once we have somebody who is having thrombotic complications, and we're able to maintain that person 2 times the normal, I think we are good with that dose of the drug they are giving. And this have to be continuous. We have to be monitoring this patient in the laboratory. And so that is why we don't say laboratory diagnosis in thrombosis, we say laboratory management. It's part of the management. And so when somebody says he wants to be the one to do everything, most often our people die. And that is why, because our medical system, healthcare system here, we are not used to litigations. That's why people can say they want to do the job that does not belong to them. People are running away from doing other people's jobs. Even your own job, you are scared. I tell somebody, in America, the doctor will not think out of the box to give you any treatment that is not as routine in that hospital. They just apply what the hospital has, put as routine, SOP. If it is chloroquine for malaria, that's what the body prescribes. Yeah, a doctor here has the liberty to say, no, because of this, because of that, I'm not going to use chloroquine. You can't say that you are not going to use chloroquine there unless you've called a clinical meeting. Meanwhile, this is emergency. And so we are looking at situations where we have to work together, like the chairman said earlier. Why do we have to quarrel all the time? We quarrel because of knowledge. It's in Ecclesiastes. That thing that God has put in you, knowledge, is the reason why we quarrel. Doctors want to look at us as the olden days lab technologists whose job is just to do PCV without. But these days the program has changed. We did anatomy, physiology, and biochemistry with the medical students. So that is the basis of medicine. And so you reason with what you do. And so somebody is telling you, no, don't do it this way. You say, no, because this is what you are. And that is actually the reason why we quarrel. But we need to find a way to talk to each other. I was discussing with a colleague this morning, and we were talking about this. Not until you look at me as a human being would you tap from my knowledge. Not until I look at you and I respect you would you share your knowledge with me. That's the way it goes. And so the patients are suffering. Our patients are dying. And because there is no good jurisdiction mechanism, people just die and we accept it as the fate of God. In America, where you see street, have you ever fallen from a... Have you ever been beaten by a nurse? Have you ever had social complication? Call this number free. All you need to do is call a lawyer. Toll free. Give your story. You don't need to appear in court. You just see money credited to your account. The lawyers is 30%. That's what they all hustle for. So you realize that once there are scavenger lawyers, even when the patient says I don't want, they will tell you you should. You should go to court. And so a lot of things are happening. Children will die unnecessarily. They will just say, well, God gives, God takes. That's not correct. So we need to look at that, the clinical aspect, the drugs they use, but our job is laboratory control. And who are you if your own is just a messenger and somebody is your controller? So you have to, and on our part as a controller in managing thrombosis, we need to know how these things are done. These days, automations are coming. We are happy. But automations are creating a lot of problems that we may not be able to handle. But if you get to court, nobody tells you, you don't tell the court, the judge, that it was automation that gave you a wrong result. You maneuver the wrong result. And so we still need to know how to do all these things. And I know in every hematology lab, there is always a focal person for prothrombin time, partial thromboplastin. Most people run away from it because they don't want trouble. But these are things that makes a difference, that makes you to stand out amidst the more that you can do. So note that even though you have been given all the complexity of tests, the D-dimers, the blah, 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 the basic coagulation profile is where we were trained to start from. You don't leave with malaria and start thinking of cancer. You just be surprised that it's a very simple thing that is causing this with this common thing. Then you now go specifically and try to identify where the problem is. Next slide. So thrombotic markers, like I said, these are all things that can come under the diagnosis. I know you've done a lot about this. My own is just to list them out for us to see again. Next slide. Now, we are coming gradually to the theme, eyes on thrombosis. What is our own perspective here? I said at the beginning that we feel these things are not existing because we don't have the knowledge. We are not exposed to a lot of things happening. In developed countries, venous thromboembolism is already a serious public health problem and ranks among the main causes of mortality. Mortality from this disease is also increasing in non-developed countries. Little is known about the biological, epidemiological, and clinical risk factors of thrombosis and venous thrombosis among black Africans. A Senegalese study revealed that oral contraception, immobilization by cast, surgery, and non-blood group O were significantly associated with venous thromboembolism occurrence. That's the best I could get in the literature. And of course, it went further. Next slide. That the prevalence of DVT varied between 2.4% and 9.6% in post-operative patients. It gave all those details for the Senegalese population and the African population in Senegal. Next slide. Somebody said, Steve Maggie said, there is no shortage of dead people in graveyards that got there through blood clots. There's actually no shortage. If you feel that these things are not around, they are around. A lot of people are dying because of thrombosis. If I can tell you categorically, 90% of our elderlies, this is what kills them. This is what kills them. They just see that they sleep and they are not waking up because they probably threw an embolus into the pulmonary artery in the night and they could not breathe, they could not cough. And so before you know it, they are gone. Everyone should come forward to spread awareness of thrombosis because it is living with us. We were born with it because as long as blood flows in your veins, you are prone to have blood clotting or bleeding problem. Next slide. Eyes on thrombosis 1. Can you click the next one? Let me see. Okay, no, go back. Who should be investigated? Patients with vitamin K antagonist induced skin necrosis, patients with arterial thrombosis or venous thrombosis, children with thrombosis, women with pregnancy complications or failure, women in assisted conception procedures, oral contraceptives generally. Because most of the time you find out that there is an implant, there is this, there is a whole lot. All they do is they give hormonal therapy. And this hormonal therapy needs to be well regulated. But people just take it because it prevents pregnancy. Asymptomatic, women on oral contraceptives or hormone replacement therapy. The hormone replacement therapy is the issue that I really want to talk a little bit about. This happens when somebody is just getting into menopause. And the hot flush or flash season comes up. It's not, she's confused. Today is this, tomorrow is that. All complex complications, complaints are coming up. And they find out, okay, what's your age? I'm 50. When was your last period? Now it's no longer regular. Once it comes in 3 months, I don't see it in another 4 months. They are beginning to look at you as menopausal. And so, because you have headaches all the time, you have all sorts of complaints here and there, they give you estrogen. You remember at the beginning, we mentioned estrogen. Because estrogen is the one dwindling as the woman ages. And once you give a shot of estrogen, she gets bumped back again and she's happy. Headache goes down and she's thanking the doctor. But it to be monitored. And just because you're also displacing estrogen and follicle stimulating hormone during the time you are giving contraceptives, you also need to monitor it because you are disrupting the natural setting of the person. And so things need to be done. Then surgical asymptomatic first degree relatives of VTE patient, because we mentioned the genetic factors earlier. So it could run in the family that this is the kind of blood vessels they have. Surgical and other hospitalized patient, because he's been hospitalized for a long time, when he gets up from the hospital bed, he needs to gradually do exercise to see if they, but most often they give them anticoagulants. And the anticoagulant they give them may end up destabilizing the system again. Okay, so patient with history of repeated episode. Next slide. Now, keep your eyes on these following points. Pain in one leg, usually the calf or inner thigh, just one of the two legs. Remember that first history. Raul was having pain when the swelling in one leg, edema in only one leg. And so most often this thing comes with just one leg. And you feel, why should it be? It's not the two legs. It's beginning to be a sign of thrombosis coming up. We lost a relative last year, 76-year-old woman, very active, but for some time, for like a week, she said she had malaria. She didn't. The malaria actually was treated. And the first day she tried to come out, she threw an embolus. Before they could move her, she just fell. Before they could move her to the hospital, she was gone. And so that's the way. So once these things start coming, you need to, swelling in the leg or arm, chest pain, numbness or weakness on one side of the body, and a sudden change in your mental alertness. You just realize that this is not me. Then you need to quickly see your doctor. Next slide. Be careful with the following: smoking, diabetes, high blood pressure, high cholesterol, poor diet, and the last one there, old age or older age. Now, I have not said stop smoking. It is a choice. I've only said be careful. Next slide. Now you need to shine your eyes. On your everyday living, you need to exercise regularly. I did say that exercise has been inextricably linked with good fibrinolytic activity. And so runaway clots can easily be taken care of when you exercise. It's easier to say, go and exercise. It's when you start exercising that you realize that there is a problem in it. But I urge you to continue. Because at the beginning, there is this inertia forces that weigh you down. Especially you start having muscle pains and this. Once you have muscle pains, it's as a result of that. You may not even need to take Panadol. It will resolve in 8 to 9 days. If you continue with that exercise, you get to a point where you start producing what we call happy hormone, the endorphins. The moment you start secreting endorphins, it means you are beginning to have the beneficial effect of that exercise. And so any day you do not do your exercise, you are not happy. Something reminds you when you wake up that you need to exercise. And so you quickly go and do that. So when you do that regularly, it becomes part of you. Eating a low-fat, high-fiber diet. Check your BP regularly. Drink plenty of fluids, but avoid coffee and alcohol. But some people are in love with coffee that they can't do anything without it. I don't drink coffee because it excites my heart, and I was able to know that too early. Once I take coffee, I hear my heart banging. That's exactly the effect of the coffee, because all it does is to keep you alert, and so it increases your heart rate and pumps blood very fast. So that, but I think my heart says you don't need this, so I quickly recognize that. After surgery, anticoagulants, heparin and warfarin, you need to, if you are on these drugs, and there is nothing wrong in you asking a doctor, why am I giving this drug? It's just discharging you and you're going home and it's giving you some drugs, take one a day. What is this drug for? Some may not want to tell you because they don't want you to go and buy. It's all fraud. There's no reason why a patient should not know what he's being treated with. If he likes, let him go and buy from the chemist. If he dies from there, that's his business. When traveling, especially for a long, long haul, stretch your legs, flex your feet, and is there a way you can raise that thing up so that they see the last one? Raise the projector up a little. Yes, press your toes down. You can do that often so that even when you are sitting, you can be doing that. Even as we are all sitting down, we've been sitting down for about 2 to 3 hours now. We need to, after this lecture, get up and stretch yourself. Next slide. Now, proper treatment is necessary to fight thrombosis. And for proper treatment to take place, proper tests are needed. Who are the people to do these tests? Me and you. I was introduced as being on the bench before going into academics. I am still on the bench, Oga. I'm still running one small workshop in Benin. And that is the basis of my existence in this COVID era. No salary. For proper tests to be done, there is need for the stakeholders to have proper knowledge of the disease through training and retraining. And that's why I commend this society for organizing this. Because we need to be aware. We need, if you don't know what you are going to teach people, then what are you doing? I kept saying this. I went to US in 2015 to go and learn. I was already an associate professor waiting to be promoted to professor. And I knew I was going to start having PhD students that I will be training. I don't want my students to be ahead of me in knowledge. I went to do molecular biology training. So that I talk, I'm beyond you in what you are doing. So that you don't just come and start giving me us talk and boost stories. So we need to continuously train and retrain ourselves. Anywhere you see knowledge, go and sit down there and listen. You are not losing anything. Understanding the basis of the disease is as necessary and important as the disease itself. We should avail ourselves of this opportunity to educate ourselves about this life-threatening disease called thrombosis. Adaptive mechanisms to life-changing events as one ages should be encouraged so that we can forestall the consequences of thrombosis. Next slide. I used to say this, but I modified it a little this morning. What we learn, we know. What we know, we do. What we do, we see. And what we see, we believe. Coupling knowledge and belief with intelligent reasoning is the basis of medical laboratory science practice. And we, me and you, the proud practitioners, are fully equipped for this natural yet scientific road that God has bestowed on us, no matter the distractions. And what we are medical laboratory scientists. We are God-sent able hands in the hematology world. Nobody can take that away from you. It's only council that can withdraw your license if you misbehave. We are God-sent able hands, and of course we care for everyone. So we are the unseen heroes, but noticed by the Almighty God. Next slide. These are a few of the references I've used. I just felt it necessary to bring them. Can we have the next one? And usually, looking forward, there is a gray area. You want to do research on, in or on thrombosis. I was discussing with a colleague this morning. This is an area that you can feast upon in this part of the world to do research. You may not have human beings to use, but the best researches these days are done with laboratory animals. There are methods used to reduce thrombosis in lab animals. And you can from there look at this, look at that, look at this, look at that, before you can take your research to humans. Because I know the problems we have when we want to do research. Some of us find it difficult to even initiate a research. But our contemporaries that we would have been doing researches with are the ones with that flying shoulders that these people can. And the moment they do that, there is no way, no matter the automation that comes, you need a lab scientist when you want to do a research on thrombosis. You definitely need a hematologist. And I want to encourage us to find a way to get into this, and the sky will be the limit. Next slide. So, I used to, just next one too. I will say, you pardon me. Next one, if I have not satisfied your intelligent reasoning on this topic, no one knows it all. But I always say, the next one, I always say, I will try next time to do better. Next one. I want to say thank you in so many ways, so many languages. Maybe I don't understand your own. If your own is not there, forgive me. Thank you very much for this.
Please, let's keep clapping for our prof until he gets its seat. Thank you. That was a breathtaking lecture by Professor Ifedayo Ajayi from University of Benin. The first time I witnessed his lecture was in Ibadan when, or during our HBTSSN Southwest Zonal Workshop, and he has given us more than even what we expected to hear from him. Once again, let's give him a round of applause. I've been asked to tell us that any moment from now, our chairman may be taking his leave. Please, if he still wants to enjoy the lecture, he can stay with us. Otherwise, he has other function to attend. But very quickly, we'll be bringing in the next person to take us through preventive thrombosis and promoting high quality of life. That is to be taken by Dr. Mrs. Evelyn Eze. Thank you, sir. You're welcome, ma. You're welcome, ma. Again, the lecture materials will be sent to you as long as you registered for this program. So just sit back, enjoy the lectures. They will send your materials to you as soon as you get your certificates. Thank you.
Good day, everyone. My name is Dr. Evelyn M. Eze. May I stand on the existing protocol? I'm here to make a presentation on preventing thrombosis and promoting high quality of life. Next slide. Next slide. These are my presentation outline. Next slide. Okay. Of course, our prof and other speakers, they've talked so much on the overview of thrombosis and the various types of thrombosis. And of course, the associated risk factors. We've seen quite a whole lot of risk factors for thrombosis. And we know that some of these risk factors are hereditary, which means that there is nothing we can do about them. We have to live with them. And then probably what will help us is being conscious of it and employing some preventive measures that will help us not to come down with them. And also, we also have some acquired risk factors. And these risk factors, they all have different levels of thrombotic risk. The levels are not equal, which means that they can predispose to thrombosis at different degrees. But one good thing about some of these thrombotic events, like I said, is that they can be prevented. So there is still hope if only we can do the needful by being conscious of those risks and applying the measures that will be outlined. Some of them have actually been outlined, but we'll still see some of them. And then we also want to look at these thrombotic events and try to see how it affects quality of life. And if we are looking at quality of life, is a concept that reflects a measurement of various issues of health status. We are going to see it, and we are going to look at several definitions of quality of life. A lot of people had made several definitions that define quality of life in different ways. We are going to see all of that today, including the WHO. The next slide. Some authors have defined quality of life. Of course, it's a multi-dimensional concept that involves the social aspect, the interpersonal aspect, the environmental system of an individual. And it's not just health. Quality of life is more than just health. There are other aspects. And it is the degree to which a person enjoys the important possibilities of his or her life, according to Renwick and Brown, 1996. That's how they saw it. Next slide. Then WHO looked at it and said that it's a complex way where a person's physical health, psychological state, level of independence, social relationship, personal beliefs, and their relationship to silent features of the environment. It is a holistic concept that involves all of this before you can actually say that somebody has a good quality of life, not just a mere absence of disease. Next slide. I will not talk so much about the risk factors. Prof had just mentioned virtually all of them. Next slide. Next slide. Next slide. Next slide. Okay. So, having known some of these risk factors, West and his colleagues, they made a prediction. They have a score that you can use to predict deep vein thrombosis. Next slide. So these are the parameters, the clinical parameters they looked at. And the other, you have the score. And they came up with the fact that if at the end of the day, you have a total score of equals greater than 3, then that individual has a high possibility of coming down with thrombosis. Then for those that fall into moderate possibility category, if their total well score is 1 or 2, and of course for the low possibility, if it is lower than or equal to 0. Next slide. The focus of this particular presentation is on prevention, and then vis-a-vis quality of life. Of course, prevention, they say, is better than cure. We know that. If we can prevent it, why do we wait for when we come down with the sickness to begin to take medications? Of course, we know that medications will always come down with their side effects. So, first on the list of our preventive measures is lifestyle changes. Of course, we've seen obesity is one of the major risk factors for thrombosis. And we know that if we can change, go to the next slide. If we can change our nutrition, these days a lot of people go for junks, probably because people are on a fast lane. You run out of your house from in the morning, come back very late, no time to take good meal and all that. We resort to some of these junks, and these junks are not good enough. They will predispose us to some of the risk factors, and which means that we need to have a change in our nutrition. We need to go for whole grain foods. They will do us a lot of good. Fruits and veggies, instead of all those high calorie food. Then exercise. Exercise can never be overemphasized. Prof has said so much about it. And we really need to do exercise, no matter how tight our schedule is. You know, we know that aging, increasing age is a risk factor. And once you are born into this world, you must increase in age, which means that everybody is at risk of thrombosis if care is not taken. If age, increasing age is the factor. And that is why we have to start exercising early. And of course, ambulation, this one is for people, maybe people that are sick, the ill, inpatients, hospitalized patients, you know, or women that are taking a bed rest, probably because they are having a problematic pregnancy. They need to, from time to time, or even people that have just had surgery, you get down from the bed. In fact, some doctors, as soon as you're done with your surgery, maybe the next day, some doctors will come and tell you, come down, you know. You'll be like, I'm still having pain, and this doctor wants to force me to walking around. He's trying to help you so that you don't develop this deep vein thrombosis, because immobility is a very big risk factor. So ambulation, you just come down from your bed, walk around a little, and then get back. Then if you're smoking, I would say quit smoking if you know that you're in the risk factor group, because some of these factors, they are just not in isolation. Particularly if you're a woman that is pregnant, your pregnancy is a risk. If the woman is obese, obesity is a risk, which means you already have two risk factors to battle with. And then you are smoking again on top of it. The risk factors are increasing. And as the risk factors are increasing in number, the probability of you having thrombosis is equally getting increased. So quit smoking if you have been smoking, particularly for pregnant women. Then of course, we try and avoid long periods of staying sedentary. Prof has mentioned air travel. He used air travel as an example. Apart from air travel, we know that most people equally do land travel, long land travel, car travel, traveling from here to Abuja. Most of the times will not just take you less than 8 hours or even 10 hours because of the bad road. So find out, I know that if you are using vehicles, you know, sometimes vehicles, they have some points they stop to eat. Even when you're not hungry and you're embarking on such long journeys, try and come out of the car, stretch your legs. Don't just because you don't want to eat on the road, you know, you just stay there. If you stay there, you are exposing yourself to deep vein thrombosis. It's not just air travel. Next slide. Then of course, the pharmacological preventive measures. These are some of the drugs. Some of these drugs are used as prophylaxis for some inpatients that are prone to thrombosis. So I'm not going to talk so much about it. Dr. Okam has said a whole lot about the pharmacological intervention. Next slide. The mechanical prophylaxis. This is mostly used for people that for inpatients that are prone to deep vein thrombosis. Of course, the compression stockings is an elastic stockings. It fits tightly around the legs. The essence is to help keep blood flowing towards the heart by pressure. They apply pressure to the legs. And of course, it will prevent blood from pooling and forming blood clots. So apart from compression stockings, you also see sequential compression device or intermittent pneumatic compression. So these also are plastic sleeves that are wrapped around the legs, because like we said, or my other presenters have said, mostly you find deep vein thrombosis as the deep veins of the legs. So the legs are mostly affected, even though sometimes the arms can be part of it. So this device are connected to the legs. You know, it's like if you know this pump they use to put air into tire, the mechanism is like that. It inflates and deflates, you know, the sleeves, and by so doing it will help blood flow and will hinder formation of blood clots. Then apart from the SCD and IPC or IPC, inferior vena cava filters are equally used. The essence of this is to stop the emboli, or rather to stop the clot from embolizing, from getting loose and getting to the pulmonary circulation. Because once it gets to pulmonary circulation, it could be very fatal. So that's the essence of that filter. The next slide. So I want to just give a little highlight on some specific cases. Next slide. Prevention of DVT in obesity. How do we prevent DVT in obesity? Of course, we know that obesity is a very common phenomenon. And I also want to let us know that whether we are obese or we are not obese, we should also apply some of these strategies. It's very important. It's all equally important to do it early. And we know that the obesity is one factor that has a very potential interplay. You know, it plays a very, it interplays with other risk factors. It can trigger other risk factors. So we need to really work on this factor. Next slide. How do we work on that? Of course, I've mentioned weight loss, intentional weight loss. You know those days where I'm coming from, if you are not fat and you're married, it's like your husband is not taking good care of you. But that was then, when women were called Oriako. Now we are Opatako. We are weight makers. Therefore, we need to really maintain healthy weight. Not like those women of those days. And that is why sometimes you just hear that this woman slept and didn't wake up, or this man slept and didn't wake up, because of some of these issues. And we Africans, we like shielding ourselves or removing ourselves from you know, we want to exonerate ourselves from being the reason for our problem. Instead, if we don't say that's God's will according to Prof, we'll say that is a spiritual attack, or it is coming from one old uncle or old aunt in the village. Please, let's do what we are supposed to do and leave all those old uncles and aunties to be, because most of our problems were at the cause, sometimes ignorantly. But I believe after today we'll be very much aware as to be able to avert some of these problems. So intentional weight loss through diet control and of course physical activity, physical exercise. The role of physical exercise cannot be overemphasized. We really need to do exercise. If you have not been doing exercise, make out time to do that. Make out time. And of course, for the obese people that have obesity, vitamin K antagonists can be prescribed by clinicians. We have quite good number of them. Next slide. And these are some of the authors that have really worked on the effect of obesity, on effect of physical activity, on risk of venous thromboembolism, and of course Lucy et al. They reported that moderate to high intensity physical exercise was associated with reduced risk of venous thromboembolism compared with low level of physical exercise. And of course, other authors also worked on diet, and we are seeing it. They came up with the result that a diet intake rich in vitamin E and vitamin B6 and fiber was associated with a decreased risk of venous thromboembolism. Next slide. How do we prevent DVT in pregnancy? Knowing that pregnancy is a risk factor, there are other different steps that you can take as a pregnant woman to prevent DVT. Of course, there are some exercises that are safe for a pregnant woman. A pregnant woman is not supposed to be do strenuous exercise, but then you can take a walk. Walking is a very healthy exercise, and some other exercises that your doctor may prescribe for you. Then if a pregnant woman has or reason to fly, the person has to wear flight socks, and he's supposed to walk around at least once every 1 hour. Once every 1 hour. In fact, the best way to do it is that you take a lot of water so that you'll be feeling pressed. That's the unconscious way of doing it. Just take water, you feel pressed, you want to go and use the toilet, you know. That will make you to at least walk. And then, of course, you are supposed to move your legs. Even as we are seated here, just like what Prof had told us. You move your legs, and then from time to time, you can, the woman can walk around, and then the ankles, you flex the ankle, you lower the heels, then you can, the person can wear support hose, and most importantly, the woman has to quit smoking if the woman was smoking before. This may not be a major issue down here, but over in the advanced world where anybody smoke anyhow. The next slide is an issue. And it is also recommended that all women should undergo an assessment of risk factors for VTE in early pregnancy or before pregnancy. You know, there are some people that have familial history. Some may even have had positive medical history. That's the essence of this assessment, so that all the risk factors can be assessed from day one, and then the pregnant woman will be properly followed by her doctor, so that there will be nothing like emergency. And of course, this assessment, if a woman is at risk, the assessment should equally be repeated if the woman is admitted to the hospital, or if the woman develops other problems along the line of the pregnancy, or even after delivery, because once postpartum is still a risk factor. Then, if women that have been on thromboprophylaxis with a low molecular weight heparin, they can also discontinue. They need to tell the clinician or their doctor about this. Then, of course, for women with ovarian hyperstimulation syndrome, they should also be considered for thromboprophylaxis. Next slide. IVF, women with an IVF pregnancy, and 3 other risk factors should be considered for thromboprophylaxis with this low molecular weight heparin. Starting in the first trimester is a preventive measure. And of course, even after, as soon as the woman delivers, there should also the first thrombophylactic dose of low molecular weight heparin should be given as soon as possible after delivery. Of course, provided that the woman did not have or is not having postpartum hemorrhage, or there was no local anesthesia being used. Next slide. Then, thrombosis and quality of life. You know, when we have people that probably are hospitalized, when they are out of the hospital, when they are discharged, most people think all is well, but this is far from it. This is far from it. There are a whole lot of cases where this is not true. So how do we look at quality of life? We use quality of life as a measure to determine the outcome of clinical care. We also have health-related quality of care, and we know that this health-related quality of care is known to be impaired in patients who develop post-thrombotic syndrome following deep thrombosis. Next slide. We have a lot of people, a lot of researchers who have worked on quality of life, and Powell is one of such researchers, and he came up with this model. In his model, he said that quality of life can be objective, it can also be subjective. And we see that for the objective aspect of quality of life, you have behavioral competence, where leisure activities are inclusive. You also see the environmental quality. Of course, the environmental quality, the structure and the process of care is considered under environmental quality. Then you're looking at the subjective end, the perceived quality of life. The perception or your perception about quality of life can be subjective. The way I perceive quality of life may not be the way you perceive quality of life. Even time, they play a role in defining how we perceive quality of life. And then our psychological well-being also is a factor that determines how we perceive quality of life. Next slide. Then apart from Powell, we also have another authors that had their own concept of what quality of life is all about. And you can see from the slide, they have about 5 categories. They look at quality of life from the physical perspective, where personal safety is how safe are you in your environment, goes a long way to tell about your quality of life. Then the health, how healthy are you? Are you down with any illness? The fitness, the mobility. Sorry. So these are the parameters that determines the physical aspect of quality of life. Then they look at it from the material end. They look at it from finance. How buoyant is your finance? They even look at it from the finance. How buoyant is the finance of the economy? The housing, not just the housing, the transport, security, and the others. Then they also looked at it from the social aspect, relationships. They look at community, the community, and then of course They also look at the development and activity and emotional well-being. So these are the way they looked at quality of life in all these perspectives. Next slide. Then Rand in 1990, they developed this 36 F36 is an item, a short form health survey, item that they can use. They can use it to measure different dimensions of health-related quality of life. So this SF36, like I said, covers 8 different dimensions of health-related quality of life, and these are the area that are listed: the physical functioning, the social functioning. You look at role limitations due to physical functioning. You also look at role limitations due to emotional functioning, the bodily gain, general mental health, vitality. This vitality, when you talk of vitality, you're looking at the energy and the fatigue. Is the person tired, or is the person energetic? These are some of the factors that are considered, and also the general health status of the individual. Next slide. Next slide, please. So, the essence of looking at that is for us to see, we've all seen different aspects or different indices for measurement of quality of life. Is there any way that thrombosis affects any of these parameters? The answer is yes, as we are going to see now. We discover that even when somebody survives from DVT, the quality of life of that individual can still be impaired, because some of these come down with some disability. Apart from disability, it can come down with the fact that the person is meant to be taking some medication every day, and some of these things can affect somebody's entire well-being negatively. So, to discover that most DVT survivors have been found to be frail and have poor physical function long after their initial DVT event. We also discovered that former DVT patients, especially the elderly, might have difficulty moving and performing simple tasks, such as walking up and down the stairs. So these are things that impairs their quality of life. They may need to be helped. Somebody that has been agile, that has been doing her things or his things by himself or herself, now he needs help. It could be so emotionally disturbing. Patients can become socially excluded. These are issues because of the disorder, they can lose contact with their social network. Even because of the thrombotic disorder, they may lose their work. If somebody cannot work properly anymore, the tendency that the person may be out of work is there, because the person will not be contributing much anymore to his or her organization. So you see the person losing out of work in some cases. And then the survivors that often, of course, encouraged to often engage in lifestyle changes, things that they don't used to do before, they are now forced to. It's like they are now being forced to, so as to avoid another attack. Because once you've had it, the reoccurrence is a possibility, and then the person is meant to do things, and the person is conscious that if I don't do this thing, it's just like somebody that is sick and you're telling the person that, oh, you just have power to live, to pass on. You know how traumatic it can be. Next slide. We have seen that patient may be admitted to the hospital for a single attack, but may have to continue their medication for the rest of their lives to remain risk-free of these thrombotic disorders. We also see that patients on anticoagulants become exceptionally scared of injuries. You know, because some of these anticoagulants, they can predispose them to injuries. And of course, if they have injuries, you know what it means. It can predispose them to bleeding. And if they have injuries, they can bleed heavily. And that's why I'm afraid. So fret is part of the aftermath of this disorder. Then some people like sports so much. In fact, that is their hobby. Or they are involved in other things, other physical exercises that give them good joy. But now that they have had this, they may be forced to give up such sports, particularly strenuous sports, you know. They'll be forced to give up to those ones and begin to do minor ones that may be healthy for them. And these things affect them emotionally in a very huge way. Then, they also know that coping with these adjustments, they have a lot of adjustments to make. A lot of adjustments. If they must continue to live. And because of such consciousness of such adjustment, they have anxiety. They can come down with anxiety. Sometimes depression can set in. Even some may even begin to contemplate suicide. Can be as bad as that because this disorder. Next slide. Of course, fear of the future is there, and this fear of the future can bring frustration. It can bring anger. Sometimes they will just be angry for nothing. To you, maybe for nothing, but for them, because of their frustration, they just want to. That's the way they want to show their frustration. Then some look at it as loss of, you know, they have lost their self-esteem because now they can't do anything by themselves. They must rely on somebody to help them. So these are some of the issues that affect quality of life of that individual. And people that probably were affected, severely affected with pulmonary embolism, they may go for surgical thrombotomy, and of course, after going for this surgical exercise, they always have recurring chest pain. So they may have to live with that recurring chest pain for life. Normally, on average, you see that quality of life improved during the first 4 months following deep vein thrombosis. However, in about 1/3 of patients, it is not so. It's because our quality of life deteriorates. It deteriorates. And it can even, at 4 months, average quality of life remains poorer than population norms. Quality of life of that individual. The next slide. A lot of researchers have tried to look at the effect of DVT on quality of life. And Ziegler and et al. In 2011 They investigated the long-term clinical outcome of individuals with first DVT. And their finding is that 82% of these patients suffer from recurrent symptoms. That was their finding, with a mean follow-up period of 6.6 years. Then other researchers also worked on health-related quality of life after the deep vein thrombosis. And they came up with their findings that the 5 aspects, the EQ5D, which includes mobility, usual activities, self-care, pain, stroke, discomfort, anxiety, and depression. All of the 5 parameters from their study were impaired. Patients that suffered from deep vein thrombosis. So you could see the amount of devastation on the patient quality of life, even post episode. The next slide, and that's my conclusion. We have a whole lot of things to talk, but time will not permit me to go on and on and on. So in conclusion, we have seen that the combination of multiple risk factors is associated with increased risk of thrombosis. We also saw that early recognition and preventive strategies are important, and quality of life is an index for examining the effect of diseases, therapies, and health care. And in evaluating one's quality of life, we should remember that patient is not considered only as a case, but as a human being living a life of multiple aspects. Investigating quality of life plays a key role in evaluating the effectiveness of medical intervention. And the awareness of the patient's quality of life also enables the medical team to be able to give that patient the required med care. Next slide. These are my references. Next slide. Keep going. Thank you for listening.
That was a perfect presentation by Dr. Evelyn Eze. Once again, a round of applause for her. Yesterday, our question and answer section was supposed to be handled by Dr. Okezie Okamba, but I think there was a little adjustment, and we called on Dr. Rose Amechi to handle that. So today, we will be inviting together to the rostrum Dr. Okezie Okamba to take charge of the question and answer section. Please, if your hands are not too busy, kindly put them together. So welcome you. You're welcome, sir.
Thank you so much. Hello. Good afternoon. I really want to thank the organizers of the program, particularly Professor Jeremiah, for giving us the opportunity to be here today. Also would like to thank the AMSEN chairman and all the hierarchy. I appreciate the lectures delivered by our own dear Professor Ajay and our own Dr. Eze. Professor Ajay, I want to say thank you so much. You really applied the knowledge of physiology and explained in details, the hematologic concept of thrombosis. I want to say that my coming here is never in vain. I'm Dr. Okamba. I came from Abia State University. True. Having said this, let me say that Prof took time and didn't wait enough time also to deliver a lecture. I would have loved to say that maybe that lecture ought to be 1 week lecture. Prof delivered it in the space of 1 hour. And I will really appreciate that. Please, I don't know if any of us must have been properly informed, or you still have 1 or 2 bias that need to be clarified by virtue of what Prof has said. I don't know. I would have loved to. Okay, thank you so much. Can we have maybe 5 persons to have 2? We have 2. We've gotten 2 persons. The 3rd person. Any other person? The 4th person. Maybe the last person. Thank you, man. So we have 5 persons now. Please, let me start by allowing us. Please, you tell us your name. Okay. You tell us your name, and then let's have the question. Prof, perhaps you will take the questions at once. Maybe then you start answering. Okay, please.
Thank you very much. My name is Mrs. Jeremiah Ngowari Ogbokri. I work in UPTH. My question, sir, first of all, I want to really appreciate you for the lecture. It was well taken. You were trying to establish the link between blood flow, blood pressure, and turbulence or resistance, as you put it. And then you try to tell us that there is what is called Reynolds number, which you can use to measure the turbulence. Now my question is, as a medical laboratory scientist, is it our job to do that, or is it entirely the clinician's work to do that measurement and to know, linking BP, because we regularly hear about BP, even amongst us, we hear about BP issues. And now we are getting to know that there is a way you can measure it to understand the turbulence of blood flow inside the system, and therefore prevent thrombosis. Is there anything we can do to help ourselves and to help patients around us as medical laboratory scientists? That's my question for you. I also have a question for the second person.
Okay, no, just for Prof for now. Please, the next person.
Wow. Okay, all protocols are duly observed. My name is Dr. Oluwayemisi Olorode from Niger Delta University. I'm highly delighted to be part of this workshop. Even though I'm a microbiologist and a medical lab scientist, but I still gain a lot in this workshop since yesterday I've been attending. So thank you very much, Professor Ajayi, for a wonderful presentation. To my question, sir, you mentioned some thrombosis markers. Could we associate those thrombotic markers to genetic markers when it comes to molecular research in thrombosis? Then, like, what I mean is that, do we have any gene that is associated with thrombosis when it comes to molecular research? Then what is the mechanism, sir, if we have any? Then my second question is, you talked about thrombosis in children. Is there any other condition that could bring thrombosis in children aside hereditary? Thank you.
Please, the third person.
Good day, my very senior colleagues. My name is Mrs. Wena Emmanuel Justina. I'm in the Department of Hematology, University of Port Harcourt Teaching Hospital. My question to Prof is, when he was talking about resistant factors, about the blood vessel diameter, and I realized that he mentioned that a drop by half increases resistance by 16 times. So I just really want to know, is there any measure on which this assessment can be done? Then 2, as medical laboratory scientists, is it also our role to know how to get these measurements? And then, is there a solution if there is a risk factor? Thank you.
Yes, there is somebody up there.
I'm Kowata Daniel, River State University, Medical Lab Science Department. Prof, thanks for your lecture. When you were presenting, especially on the area of the triad on formation of thrombosis or in thrombi, you mentioned that anemia could cause turbulence. It was one of the factors that can cause turbulence. Please, can you throw some light on the mechanism on how anemia causes turbulence? Thank you.
Hello? Maybe the last one, yes. The fifth person.
Thank you very much. My name is Dr. Mrs. Rosa Amechi. I'm from Ambrose Ali University, Ekboma. I want to appreciate my teacher. He's my mentor. He's teacher of teachers. So, sir, I want to thank you very much for that wonderful presentation. My question, there are 2. 1, during the course of your teaching, you made mention of automation being a problem. Then when this problem shoots up, what do we do? Then the other one I want to know is, what are the cause or causes of feedback mechanism? Thank you.
Professor.
Thank you. Thank you very much for the lecture. I mean, I said lecture, for the questions. The first one by Mrs. Jeremiah, right? Thank you. Asking for the relativity of blood flow, pressure, and turbulence. And I think the bottom line is the Reynolds number. Who measures it? Yes. It will be out of the purview of the med lab scientists to do that, because there are what we call the clinical measurements, which is not laboratory-based measurements. These are basically physiological measurements, and you need a lot of training to also be able to do that. But there is nothing wrong. A med lab scientist can be adaptive to any of these things. All you need to do is to get the training, get the equipment, and you are doing it. It's just to get a plethysmograph and that can give you the Reynolds number and all those, and you are in business. It's just that these days we don't allow the physiologists to work in our lab. The physiologists are now trying to see what they can also do to make themselves professionals as well, so that they can they are also very necessary. Some hospitals are smart; they are employing them. ECT, ECG, EEG, those are clinical measurements. Those are their jobs, and that's what they are used for abroad. But we just train people. Once they can't get admission to medicine, we load them in physiology, anatomy, biochemistry, and they come out roaming about the street, not knowing what to do. But I am the National Public Relations Officer for Physiology Society of Nigeria. We are at the verge of trying to see if we can professionalize it, and so that people who graduate can also work. So I think we have enough to do in our labs. But if you can do, there's nothing wrong. Then the thrombotic markers, the second question. I think I answered that question. Whether there's a link with the genes. Yes, of course. Anything that we measure chemically, especially in this case where we have genetic factors, we actually can assay some of the genes that are associated with some of these, like factor 5 leading, prothrombin, and even protein C and all those. They are secreted by cells. And as long as they are secreted by cells, those cells have nucleus that directs what they do. And so if there are nucleus that direct what they do, then there are DNA involvement. And so we could see what actually is the problem. Is it that some of these gene proteins are not well elaborated, or this and that, or there is a mutation in the in the genes, in the arrangement of the amino acids and this and that? We could actually do that. And of course they are doing that abroad to know they classify factor 5 leading to different genetic groups. And that is why they do much better than we do. Because they know what to give to a particular group to solve the problem. They know what not to give. But if we have to treat that in Nigeria, we'll just give the general known drug. But if it works, you thank God. If it doesn't work, you thank God as well. Because if somebody dies here, we say either good or bad, we thank God. So, but there are definitely things we can do. And you were also asking if the children thrombosis, whether it's only hereditary. No. The children, just like somebody asked if our anemia, a lot of things could. And again, if you look at the risk factors or the causes, you see inflammation there. Inflammation is not limited to adults. A lot of those factors could, even viral infection. Viral infections could go through the process of inflammatory reaction, and before you know it, it's thrombosing. And so they are not limited to hereditary. The third question was on relating resistance and blood pressure, how to measure those resistance. And just like I answered in the first question, it's a clinical measurement, but I think measurement of blood pressure, we were taught physiology at different levels. So everybody, even before we bleed our donors, these are basic things that we need to do. When we were in school those days, there was sphygmomanometer in the blood bank in UBTH. You are supposed to know the blood pressure of the donor before you put the donor on the couch. He may be having high blood pressure. You take 500 ml of blood, you drop him into hypotension, and he will collapse on the table. He will collapse straight on the table. These are things that we need. There was a lecture I gave. I said, let's make the difference. Your blood bank, that you are the manager in the blood bank, please make your requisitions of what you need. You need to take blood pressure. Put the records down. You can take. It's just like I said. We have not been seeing anything called litigation here, but we are getting there. People are getting smarter. Our children are getting smarter than we do. And if you continue like this, and we train students this way, they've never seen you as a teacher using a BP, measuring BP in your donor. Then tell me how would they learn it? So those are basic things we need to do. And even the basic thing of how to place your donor on the chair when you want to bleed. We don't do that anymore. There is a standard bleeding couch where the heart is raised up, the body is lowered in the middle, and the leg is raised so that there is enough venous return back to the heart. So that when you are taking blood from the vein, from the vein, the blood is returning back to the heart, and the heart is in a very good position to pump the blood out. The patient will not get up and start having flurry feelings and all sorts of things. We don't do that anymore, but the resilience of the black man is what is helping us. And that is what has helped us in COVID-19. I kept saying it, we are so resilient to so many things. Like this, we don't have much of hemostatic problem because we don't see it on the skin. You see the white man, you see all their varicose veins and all sorts of things. It's all over them, and they are the ones loading the clinic with the hemostatic request. Then the fourth one was the mechanism by which anemia is a risk factor. That's a very simple one, because in anemia, the blood, the concentration of the blood is low, oxygen delivery to the tissue is dropped, and the response is that the oxygen tension is censored, and the brain responds almost immediately through the sympathetic nervous system by firing the heart. Send a very massive signal to the heart to increase the rate of pumping. So that what you don't get in terms of concentration delivery, you get in terms of speed of delivery. So few red cells are available, and they are pumped as fast as possible. The heart of an anemic man is a racing heart. And by so doing, there could be injuries to the endothelium. The cells are running like no man's business. And so this could injure and again the heart may even start having issues, because the oxygen delivery to the heart may be impeded. The heart is not a selfish organ. It doesn't take oxygen from the blood within the ventricles. It will pump out first and take its own coronary circulation from the ones it pumped into the aorta. And so once the heart is relaxing, it quickly takes a very simple movement and feed itself. So the heart is not feeding well with oxygen and is pumping hard. So the heart may just even be the one that will first cause an injury to most of those coronary arteries. Before you know it, thrombosis will start, because it's actually a measure of what the endothelium cannot withstand in terms of what they are getting and what they are not getting. So a racing heart in a blood vessel will definitely have some untoward effects. Then the fifth one, automation being a problem. I just mentioned that as a possible problem, because automated equipment could go wrong, could give you some awful result at times. And if you are not well grounded in how we do our normal prothrombin time and partial thromboplastin time, then there is a problem. I still do that more often, and it gives me pleasure that I still know how to quickly get my... You see, these are manual dexterity that we learned. And so because people didn't learn it then, or they don't find it easy, they just want to dodge it, and they quickly get it. But if you must use automation, you must know the manual. There was a story of a day or a week that the automated blood banking system in the UK failed. They were in serious trouble. We don't use blood here. They could not cross-match because everything was done automatically. You know what? They were using choppers to look for Nigerians who had the MLT of those days, who could cross-match manually. Because they now have medical laboratory scientific officers, which they just train. If you are biochemists, they just post to you, just learn from. And it's all about equipment. That's what they do now. They have to look for those who can add AHG and know how to wash cells and get results and say, this one go, this one does not go. And for 5 days they were sleeping in the hospital, and of course most of them bought houses after that episode. Because of what? Because of manual dexterity. They were well trained, and so they were able to cope. For those who have never seen cross-match done before, sorry about that, there's nothing they could do. The other question on feedback mechanism, of which of them now? Yes. Okay, maybe I should just talk generally on feedback mechanism. Oh, okay. Our feedback mechanism is two ways. You have those that are negative feedback. That's actually the one that makes us to survive, to be alive. And you have the positive feedback. But the Americans call it positive feed forward. Because if you look at the differences, it's actually a positive feed forward mechanism. A positive feedback mechanism is that an action getting to the zenith will cut off the remaining action so that there is a limit to which it can go. That's the negative feedback. It has reached its peak, it calls down the source so that it could utilize whatever it is at that peak before another thing can start. And when it is dropping, it gets below a threshold. That's the language. It gets to a threshold, it stops. It gets below the threshold, it starts again. That's a negative feedback. But a positive feedback mechanism is necessary for some life-saving actions. Like the coagulation mechanism we were talking about. It's about positive feed-forward mechanism. Because when there is a breach of the blood vessel, the endothelium, the secretion, the neuronal activation starts it up. And the next thing is that one event leads to the next for the benefit of a purpose, of the same purpose. So when the endothelium finishes, the platelet starts, the platelet finishes. Before platelet finishes, the coagulation system takes off. And when the coagulation system seals the blood vessel and there is a stop to the blood flow, there is another initiation of tissue repairs. And tissue repairs is done with, there is an initiation of fibrinolysis. Because that clot at the outset that helps to stop that bleeding, if it is not removed, it becomes a thrombus. And that may be the beginning of the end for that person. And so fibrinolysis sets in. And at the end of the day, these clots are shredded and they are thrown out, they are taken out by the macrophages and they are digested. So you now see that one event leads to the other for the survival of the same purpose. The same thing happens when a woman is to deliver in the hospital. She's pregnant for 9 months. The baby is ripe for delivery. Something happens. The size of the fetus, there will have been what we call the I forgot the name of the process now. She must have been having twitches at about 6-7 months. There is a particular name we call that mechanism. Maybe I'll remember. Once you start, but as towards the end, the signal to continuously have that contraction is much. And the time comes that it gets across the threshold and there is massive contraction. And once that happens, the liquor is busted, everything starts happening. Then you see that the hormones, that the prostaglandin or the oxytocin that initiated the labor is no longer, is causing contraction. Powerful contraction from the fundus of the uterus down towards the cervical area. It's causing contraction, and each time it causes this contraction, the fetus moves towards the cervix. And and as the contraction comes, there is vaginal opening, edge coming down, and it gets to a point that oxytocin itself is not enough to cause a powerful contraction that will expel that baby. And so it recruits the service of prostaglandins. And prostaglandin has much more powerful activity in opening up the cells and allowing calcium entrance. And it is calcium that goes in that makes it much more forceful contraction. And the baby is expelled. That is a positive feed-forward reaction. If it stops at any point, there is danger. And so you see when they initiate labor through drugs, they start adding pitocin or whatever. They are actually they start with oxytocin and later they add prostacyclin, and before you know it, the baby is out. That's a positive feed-forward reaction. I hope I have explained. Thank you.
Prof, thank you very much. I was a little bit jittery when the question on how anemia, is associated with thrombosis. Because sometime about 2 weeks ago, we were at about trying to, during the Guild AGM, we were looking at a sickle cell associated hemostatic dysfunctions. So we felt that sickle cell impairs blood flow, and along the line, when there is hypercoagulation, that there will be platelet margination trying to interact with the endothelium. So, and I know it's possible when there is that impairment of blood flow is much more common when there is a high level of HCT. So, but I know that in anemia, it's not like that. So I was just trying to reconcile what Prof was actually going to answer. But Prof came from the physiology, he knows too well, to tell us about how the heart needs blood, and that the heart again is suffering from lack of oxygen. And such impairment again, the same organ whose oxygen content has been impaired is being compelled again to pump more blood. Prof, thank you so much. I really appreciate that. Thank you immensely. So we, Dr. Evelyn Eze, also rattled us so much, but this time around, systematically and gradually pushing the preventive measures to thrombosis, and of course some quality of life measures again that we can take. I don't know if we still have about 5 more persons to give us any question. If there's any way you are not clear enough, we'd like to entertain 5 questions so that she can buttress her point and will be much more clarified. I don't know if you have questions. You can, please, you can indicate by raising your hand. So, okay, we'll have 1 person. Any other person? So no, okay, 2 persons. Hello, sir. You can now help us. Maybe the 3rd one will stop there. Doc, I would like you to take as much as 5 questions that Prof took. 3 can be okay. Hello? Okay, so we have only 2 questions. Okay.
Okay, thank you very much, ma'am, for your nice presentation. My question is, during your presentation, you mentioned about hyperemesis, how it could lead to thrombosis. Could you throw more light on the mechanism how hyperemesis could lead to thrombosis? Thank you, ma'am. Hyperemesis. She mentioned hyperemesis leads to thrombosis. So my question is if she could throw more light on the mechanism how hyperemesis could lead to thrombosis. Thank you.
All protocols are duly observed. Really, is that, when I came here, when I heard of Professor Ajayi, in the first place, I thought I would meet my mentor, Professor Ajayi of ABU in those days. But all the same, Ajayi is Ajayi. Prof, you're welcome. The question I want to ask may be answered by either of the 2 lecturers. They told us that thrombosis can cause pains either in the leg, in the arms, or in the chest. And that again, aging is part of risk factors to thrombosis. Meaning that thrombosis can occur without any physical damage to the tissues. So I want to ask, sir, what is the relationship between these thrombotic pains and rheumatism and arthritis? My name is Mr. Obi LC of UPTH. Thank you, sir.
Okay, Doc. Okay, Prof.
Please, if we have the CISMES representative around, after this section, you do your presentation. Thank you.
The second question on thrombotic pains, right? Whether rheumatoid arthritis or anything they are linked with thrombosis. I think thrombotic pains in the arm, the leg, the chest, or wherever is as a result of low oxygen tension. If there is a thrombus blocking a particular passageway, all the tissues thereafter are not getting anything. And so it is the accumulation of carbon dioxide which will be converted to lactic acid. And the effect of the lactic acid, because there are the nociceptors, the nerve endings on those tissues, have receptors for that, and even for high carbon dioxide, and they can easily feed the brain to tell the brain that this is the problem. But now, if it's happening within the heart does not show pains. If it is showing pains, there is no way you can feel it. Rather, it refers its pain to your shoulder, your neck, your chest, and every other area. That we call it mechanism of referred pains. You feel pains. But the important thing is that if you take a 100-meter dash now, you get to a point that you cannot carry your legs anymore, because you have realized that the rate at which you burn oxygen is not the same rate at which you generate carbon dioxide. And so the accumulation of carbon dioxide in your muscles, your skeletal muscles, signals pain receptors, and you feel the pain. And that is to make you to stop the actions that you are going on, because you could not cope with the oxygen requirement anymore. That is fatigue. And so you stop. And when you stop, the moment you stop, the brain initiates hyperventilation, and you start gasping, deep breath. And the more you unload the carbon dioxide, gradually the pain will ease out. That's the way it is. But when it happens in vivo, when there is a blockade and oxygens don't get to those tissues, two things will happen. First, you start having those pains, and if it is a continuous thing, the tissues ahead of that particular thrombus will start atrophying. They will start dying off gradually. But the heart is so good that it will not show you that it can no longer work until it is less than 25% of its capacity. And so it will still keep pumping, and you are still active. You are gradually showing signs of sluggishness, but you don't know where it is coming from. And so finally, a day will come, it will say, sorry, I can't go ahead. So rheumatism and other things have different mechanisms with which they cause pains. But it has to do also with inflammatory reactions that brings about some painful sensations, and it goes through the same nociception pathway, but not actually acting via the thrombotic pathway. But it may lead to thrombotic tendencies, because they go via the inflammation, and they can easily go through the process. I don't know if I've answered that question. And you see, the sickle cell patients also have pains, vaso-occlusive pains, because the areas blocked off are not getting enough oxygen. And that's why you see that convalescence is low once they are like 22, 23 years old. Because at that point in time, they have lost their spleens. They've gone through the autosplenectomy process. Because while they were born, the spleen has been the one picking up those sickle cells, and each time it picks the sickle cell in the pulp of the arteries, the veins, they don't go beyond there. And so they get stuck there, and that each episode of that, the spleen goes on dying gradually, until there is autosplenectomy. They don't see less or severe of those attacks. And in the modern world today, if a sickle cell is born, they just go in straight. It is not for you to decide as a parent whether you want the surgery done or not. They just do splenectomy straight away. And the child lives moderately a normal life without pains, because he won't be going. The only pain he will be having will be the one due to hemolytic pains. And that's the only one they now manage. Thank you.
Thank you for that question. The question is the mechanism behind hyperemesis causing thrombotic episode. Of course, hyperemesis is just the morning sickness that you normally have when you're pregnant, which triggers vomiting and nausea. When you vomit, fluid is lost. And when excessive fluid is lost, dehydration sets in. And when dehydration sets in, the blood becomes, the viscosity of blood changes. It becomes thicker. And such can trigger, we saw the triad. When the blood is viscous, it affects one of the components of the triad. The blood flow will be reduced, and that could trigger thrombosis. I hope, via the hemostatic mechanism. I hope, okay.
Hello. Ladies and gentlemen, I want to appreciate Pastor Jeremiah and the AMSON in general. I want to say I didn't waste my money coming here. I've been filled, I've been satisfied with the level of knowledge. When Professor Joy was talking, he said, what we know or what we learned, we do. And while Dr. Eze was talking, she now said that prevention is better than cure. And one of the preventive mechanisms is that we should avoid sedentary lifestyle. We should get ourselves in activities. I want to claim the indulgence to request that you stand for 1 minute as we give them an applause, and by so doing, we engage in activity. Thank you so much.
Hello? 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 Distinguished guests, ladies and gentlemen, Okay. So the next on our item, it's a little break, 10-15 minutes break, so we can eat, then come back to continue with the next lecture. So let's have our food, stretch our legs 10 to 15 minutes, and we come back. Thereafter, we will be calling on
shortly after the break, we'll be having our next lecture. So we can just as well stretch our legs and hands and eat our food. Thank you.
Please, let's sit. Let's have our seats so we can, those sharing the refreshments will do it in the proper order. Please, can we just sit and get our food? Please, can we just sit and get our food?
Hematology and Blood Transfusion Scientists Society of Nigeria, HBTSSN, South Region, in collaboration with the Association of Medical Laboratory Scientists of Nigeria, River State Branch, presents a 2-day workshop in commemoration of World Thrombosis Day 2020 with the theme Eyes Open to Thrombosis under the distinguished chairmanship of Professor Confidence Kinikanwawachuku, Dean, Faculty of Science, River State University. Keynote speaker, Professor Olutayo Ifedayo Ajayi, University of Benin, Nigeria. Date 12th to 13th October 2020. Time 8 a.m. to 5 p.m. daily. Venue College of Medicine Auditorium, River State University, Port Harcourt. Workshop fee 5,000 naira. Payable to HBTSSN conferences 102-172-5802 UBA. Call 0803 331 8914 or 0803 338 4477 after payment to register for the workshop. MLSCN 3 credit units to be awarded to participants. Signed, Mr. Upwada Stowe, Councillor, HBTSSN. Working as a Newman, Secretary, Planning Committee. Dr. Serekara Christian, Chairman, Planning Committee for HBTSSN, South Region, and the Association of Medical Laboratory Scientists of Nigeria. Hematology and Blood Transfusion Scientists Society of Nigeria, HBTSSN, South Region, in collaboration with the Association of Medical Laboratory Scientists of Nigeria, River State Branch, present a 2-day workshop in commemoration of World Thrombosis Day 2020 with the theme Eyes Open to Thrombosis under the distinguished chairmanship of Professor Confidence Kinikanwawachuku, Dean, Faculty of Science, River State University. Keynote speaker, Professor Olutayo Ifedayo Ajayi, University of Benin, Nigeria. Date 12th to 13th October 2020. Time 8 a.m. to 5 p.m. daily. Venue College of Medicine Auditorium, River State University, Port Harcourt. Workshop fee 5,000 naira. Payable to HBTSSN conferences 102-172-5802 UBA. Call 0803 331 8914 or 0803 338 4477 after payment to register for the workshop. MLSCN 3 credit units to be awarded to participants. Signed, Mr. Upwada Stowe, South Regional Councillor, HBTSSN. Working as a Newman, Secretary, Planning Committee. Dr. Serekara Christian, Chairman, Planning Committee for HBTSSN, South Region, and the Association of Medical Laboratory Scientists of Nigeria.
This man. You also have to be careful. You really know that people now paying down the bill, if not the fear of God. People do not. And all of them pay, no one acknowledge the federal minister of health. The minister to be specific. Because there were a lot of things that happened. NAFDAC claimed to do this validation. Even NINA also claimed to do the validation. The minister insisted that video of clinical laboratory science transfer of Nigeria. And that we have done the first batch. Yes, we have done the first batch. None of them made the condition. And this is the second batch. So it's got them. They are not careful. The data they are on duty and all that. You can do again the more fail. And that is what we are advocating for as a profession. That our duty is given to us to do. In the right manner, the council will also go into things like PT, HIV, and all that. Because what we say is that a lot of companies are bringing out these things. Throw them to the market. You get cost of free, cost benefit. And we recollect some years back when I was the chairman, a particular company in Rivers State that claimed to be a company in Canada to be specific Eurotech. Take a piece of it and say it works overnight. And as I then, we collected some from Nigeria. Tested on a non-positive faith and we were really making. The one we're asking is to not say anything. Because the truth is that these things are not validated at all. Because we will throw everything in the market, Nigeria market, and people can use. We go to our places, especially private people.